Okay. Hello, everybody. I'm Naushira Pandya, and I'm so pleased to be able to share this presentation with you at CMDA on diabetes management in PALTC, a brief update. I'm sorry I couldn't be with you in person, but I welcome your questions and any communication you have after this presentation and after your conference. So here are my disclosures. I have grant funding from Health Resource Service Administration for Geriatrics Workforce Grant, and I have been a consultant for Sanofi. So the objectives for today's talk will be a brief review on strategies to optimize diabetes management in our setting. And then I want to talk about newer therapeutic agents to improve cardiorenal outcomes. These are not really so new anymore, but I think the application, especially in our setting, is still gradually gaining some traction. And then I want to refer to continuous glucose monitors and the potential applications and benefits of these wearable diabetes technologies. I want to introduce you to just a concept using the 4M framework of age-friendly healthcare, which you probably know is mentation, medications, mobility, and what matters most. And I chose to look at diabetes in this setting. So and I think might be a good way to approach the patient with diabetes in these four areas. In mentation, you could think about anxiety, depression, dementia, diabetes stress, and ability to cope with management or technology. Of course, with medications, we should always be concerned about affordability, what medications are appropriate depending on complications and end organ disease, what is appropriate in terms of family support, what is the risk of hypoglycemia, and the past history of adverse events. And I think diabetes particularly can affect mobility, and we need to be mindful of that. In addition to the foot exam, we need to think about overall function of the patient, frailty. Sarcopenia is related to diabetes, as well as leg weakness. And we know that neuropathy and vision status can affect mobility. And what in the area of what matters most, in addition to advanced care planning, we need to think about what state of the trajectory this patient is in, what complications do they have, what is their remaining life expectancy, and what risks, benefits, and burdens are there of this treatment, and not to mention shared decision making around diet, very important, therapy, and even the intensity of glucose monitoring. So I'm particularly enthusiastic about this approach, trying to apply this 4M age-friendly approach to diabetes. I just want to say a word about type 1 diabetes, to mention that people with type 1 are living longer and are now ending up in the post-acute long-term care setting, which is a good thing. And we need to be aware that type 1 diabetes can develop later in life as well. And don't forget, people often say insulin dependent for type 2 patients who now require insulin. That does not make them type 1. They're not insulin dependent. They have reached that stage where they require insulin in addition to other therapies, okay? So that's different from type 1. But the challenge with type 1 diabetes in long-term care settings is they're prone to hypoglycemia. They're absolutely dependent on insulin. And oftentimes, clinicians may assume that everybody in the long-term care setting has type 2 if they're in the older age group. And we may therefore forget that they require more insulin in times of medical stress, and that they can develop diabetic ketoacidosis, which may be mistaken for organ failure, sepsis, or other causes of acidosis. So it's important to bear in mind that we need to be aware of the type 1 diabetes patient. Here, I just created an algorithm for what medications would be suitable to select by clinical criteria. And we're going to present this in the upcoming AMDA diabetes guideline, which is almost finalized now. And there was a brief presentation at AMDA. So I divided people, if you look on the left, who have low advanced CKD or even end-stage renal disease. And if they have a normal appetite, no problems with weight loss, then you can use a DPP-4 inhibitor in the blue box, a GLP-1 receptor agonist, or basal insulin. However, if they're frail and have low body weight and are at risk for further weight loss, then you really should not use a GLP-1 receptor agonist. So our choice becomes more limited. Now, in the second bucket, if your GFR is greater than 30 and you have normal appetite, no weight loss, you have a bit more choice in terms of extended release metformin, DPP-4 inhibitors, SGLT2 inhibitors, and I'll talk more about that, and GLP-1 receptor agonists, as well as basal insulin. But if you're frail and with a respectable GFR, then again, SGLT2 inhibitors and DPP-4 inhibitors may not be appropriate. And those with high risk of hypoglycemia, which is the next box, again, metformin is reasonable, DPP-4 inhibitors, but you notice that basal insulin or prandial insulin is not included, nor are sulfonylureas for this high-risk group. And at the end of life, which is important, patients may already be on a lot of insulin, and small doses of basal insulin are reasonable. So are DPP-4 inhibitors, but the one you can use is linagliptin because there is no renal dose adjustment for linagliptin. So I particularly recommend that. So those are just some ways of selecting the pharmacotherapy in terms of where the patient is in their trajectory of their illness, in terms of their weight, frailty, and renal function. Now let's turn our attention to the use of newer therapeutic agents to improve cardiorenal outcomes, and they seem to go hand in hand. So we know that 40% of people with type 2 develop CKD of some range. And there's a 2 to 4-fold increase in cardiovascular disease compared to the general population, and a much higher risk of heart failure in type 2 diabetes compared to the general population. So the people we treat with the comorbidities they have, they're more or less likely to have some of these complications. So the general recommendation from the American Diabetes Association and other groups is that when you have advanced kidney disease, GFR less than 30, you can still use a GLP-1 receptor agonist such as liraglutide, semaglutide. Now we have oral semaglutide or dulaglutide because they've demonstrated improvement in renal outcomes and cardiovascular. And I'll go over some of the data. Patients with heart failure, the best choice is an SGLT2 inhibitor, unless your GFR is so low that, like less than 25 or 30, that you cannot use a SGLT2 inhibitor, then you can use a GLP-1. But otherwise, with heart failure and kidney disease, especially proteinuria, your first choice would be an SGLT2 inhibitor. It's important, though, to remember that these drugs should not be initiated if the GFR is between 30 to 45. So this is a confusing area, and I always look at each particular drug and their dosing recommendations in terms of the SGLT2 class. And I'm careful not to use this an SGLT2 in somebody who has frequent UTIs or yeast infections, and somebody who cannot drink by themselves, because you get polyuria, some volume depletion. So I wouldn't give it to a patient who cannot drink fluids by themselves. If they're dependent on care, that's probably not the right drug. So this is data from a meta-analysis which looked at GLP-1 agonists and SGLT2 inhibitors in terms of their outcome with various clinical indicators. So here we look at major adverse cardiovascular events, MI, stroke, or all-cause cardiovascular mortality. And in the red, you see GLP-1 receptor agonists. And the ones with the asterisk are those that show beneficial outcomes. So a reduction in odds ratio of MACE. And that goes for liraglutide, semaglutide, albiglutide, which is not commonly used for some reason, and dulaglutide. But you see in the green, the SGLT2 inhibitors, empagliflozin and canagliflozin, clearly show a reduction in MACE. But the DPP4 inhibitors universally are not very effective, one way or another, in decreasing major adverse cardiovascular events. When you look at all-cause mortality in the same study, again, you see liraglutide showed favorable odds ratio reduction, and so did exenatide, actually. And in all-cause mortality, empagliflozin really stands out in terms of reduction in odds ratio. The other confidence intervals cross 1. And saxagliptin is showing a trend towards a slightly adverse outcome, and you'll see more on this later. Hospitalization for heart failure, as you know, this is a common cause of readmission in our patients. And when you look at how GLP-1 receptor agonists perform, none of them is particularly convincing in terms of reduction of odds ratio, but all the SGLT2 inhibitors in the green show an improvement in heart failure hospitalization, which is very important. And again, in the blue, the DPP4 inhibitors are not particularly striking. And you see saxagliptin, which has an asterisk. In the studies with saxagliptin, there was actually an increase in heart failure hospitalizations. We're not sure of the explanation, so just be careful with saxagliptin if your patient happens to be on saxagliptin, okay, and they have heart failure. So people often have assumed that SGLT2 inhibitors are not appropriate for long-term care patients, but I've told you my opinion, and I think that's borne out by clinical consensus and studies. If you have a patient who can drink for themselves, they're not prone to recurrent UTIs or yeast infections, it's reasonable to try them, okay? So this study looked at over 700 people. It was in 2022, started on SGLT2 inhibitors as add-on therapy to metformin, basal insulin, or other agents. There was a 23% discontinuation due to UTIs and decline in renal function. However, all the SGLT2 showed a significant reduction in A1C of at least about 0.8%. And in these patients, the GFR remained stable, and there was a notable decrease in proteinuria, which, as you know, is related to improvement in cardiovascular outcomes. And importantly, people over 80 in this study showed a significant improvement in A1C outcomes without, worsening of renal function. So this is a class of drugs we should think about in our long-term care patients, but choose your patients carefully. That's what I would say. Another meta-analysis with 11 studies looking at over 93,000 patients looked at outcomes using GLP-1 receptor agonists and SGLT2s. And for each outcome, you see patients were broken down into less than 65 and over 65. The over 65s had a better outcome in terms of the 3-component MACE, a cardiovascular death just made it, and stroke. So over 65s actually showed a significant improvement in these outcomes. Okay, and I think those are indeed very usable drugs. Now, just to say, where would you not use a GLP-1 receptor agonist? So that's important. I wouldn't use a GLP-1 receptor agonist if somebody had undiagnosed gastrointestinal problems, like abdominal pain, chronic diarrhea, ileus, gastroparesis for sure. I wouldn't use a GLP-1 receptor agonist. So again, pick your battles carefully, especially if you have recurrent GI problems that I've mentioned, okay? But otherwise, you see improvement in outcomes in this area of stroke, cardiovascular death, and MACE. So let's look at other outcomes with the same outcomes with SGLT2s in the less than 65 and over 65. And here you see not much difference in MACE or all-cause mortality in under 65s did improve, but not in the over 65s. No difference in cardiovascular death, some improvement in stroke, and I think that data is increasing. Cardiovascular death or heart failure hospitalization did improve, as you would expect from all the studies we've seen already. And look at heart failure hospitalization, quite a significant decrease or improvement in odds ratio in the over 65-year-olds, and composite renal outcomes did improve in the over 65 and under 65. So again, I'm kind of, I catch myself. If people have recognized proteinuria, yes, we have them on ACE inhibitors or angiotensin receptor blockers, but I have to remind myself to think about adding an SGLT2, no matter what their glycemic control is. Okay, that's the important thing. It's to improve the renal outcomes, the proteinuria, the doubling of creatinine, and the need for renal replacement therapy. So let's move now to the use of diabetes technology. And here I'll focus on just continuous glucose monitors. There is much more technology now that is available, but I think in the long-term care setting, we need to first master the use of continuous glucose monitors, and not for necessarily for everybody. So the American Diabetes Association recommends this in several patients, and I'll go over that in a minute. And what is beneficial is the use of these monitors produces a single one-page report with visual clues, glucose excursions, what's the variability, and this can be used in your charting and to make decisions. And we know that the time in range is inversely associated with the risk of complications. So the ADA recommends for most patients, not necessarily older patients, time in range should be between 80 to 180 milligrams. And in older patients, that margin is more liberal. And then time below target and time above target can allow you to have a better look at where the problem is and how to make targeted changes. So why is continuous monitoring glucose important? And why don't we just keep going on with AC and HS Accuchecks? Well, for one thing, they're not always necessary. They're uncomfortable, and they don't tell you everything, okay? So this is an example of two patients. They have identical A1Cs, about 7%, but with the continuous glucose monitor, you see the patient on the left has huge excursions, okay? And they're only 40% in range. And this can be adjusted for different patients. Whereas the patient on the right is more what we want to see. Reasonable A1C, but 70% time in range. Okay, now is that always appropriate for every older adult? No, we have some more liberal guidelines. So here's a typical ambulatory glucose profile report. And this is easy for patients to interpret. They can see this on their app. You can print this and put it in your notes, and you can bill for it. Okay. You can bill for training, starting the CGM, and you can bill for review of CGM data in addition to your visit code. So in the green is the time in range so patients can see. And obviously, red is less than 70 or less than 54, which is clinically significant hypoglycemia, and you don't want to see much of that. Here in the yellow is over 180, and orange is very high, over 250. Now, those ranges can have been slightly liberalized for older people. So the important thing is to choose the right patient for the right technology. And that applies whether you're looking at long-term care, group homes, assisted living, or the nursing home. So if you have a healthy patient with no cognitive impairment and needs minimal assistance, you can use a continuous glucose monitor, which is intermittently scanned. So IS is scanned, where they scan a reader over a sensor on the skin, or real-time CGM, which gives you every 5-minute readings. And now you can even get every 1-minute readings on an app, okay? So time in range for older people can be more liberal, 90 to 180, and you can even adjust that specifically, okay? Our goal is to avoid hypoglycemia. Now, if you have intermediate health patients with several comorbidities, mild cognitive impairment, some dependency in instrumental activities, I look at those like assisted living type patients. Then intermittently scanned CGM is preferable. It can be helpful to the caregiver. It can save recurrent AccuChecks. And the time and range for this kind of patient can be liberalized to 100 to 100 to 200, what is ideal. And you can adjust it individually for each patient. And again, we want to avoid hypoglycemia. Now, if you have end-stage patients, such as our long-stay patients with multiple chronic conditions, cognitive impairment, dependency on activities of daily living, then intermittently scan CGM, which can be done by staff or even a family member, will avoid multiple finger sticks. In those patients, some of them don't need CGM. Not everybody needs CGM. You can, but a professional CGM, which is applied and owned by the clinician, to just give you, let's say, a 10-day view of what's happening. Why are you having such glucose swings? Where is the hypoglycemia? Why is there severe hyperglycemia? So you can use a professional CGM to give you an idea from your profile where to adjust. Okay. And here, this is from the American Diabetes Association. They have set different targets for older adults, so slightly broader range. So time above range, for younger people, we want 5%. We recommend 5% over 250. But for older adults, 10% of the blood glucose values can be over 250. And time in range, which I stress again, can be changed and individualized for patients. Time in range for younger patients is over 70%, we recommend should be in range. But for older patients, 50% in range is reasonable. And time below, this is important. We want very little hypoglycemia in older patients, so less than 1%, preferably none, but that's not always easy to accomplish. So you see that goals can be slightly more relaxed, but nevertheless, this allows you to look at profiles in great detail. So I looked at what are the potential advantages in the post-acute long-term care setting. Well, one of them would be reduction of staff time and equipment and patient discomfort in monitoring frequent blood glucose checks. I mean, we did a study, 70% of the AccuChecks that were done did not even require an insulin dose. And these were people who were routinely getting ACNHS AccuChecks. We can improve hypoglycemia detection. That's important because that's what the evidence shows. And we can detect hypoglycemia even at the end of life, which would be detrimental. And the important thing is when you have multiple patients in different parts of the facility, you can actually, with one computer access, look at several blood glucose profiles in different parts of the facility. You can look at people in isolation. You can look at people transitioning from one place of care, let's say, apartments to assisted living or assisted living to a long-term care, because these profiles are available online. You can access the patient's data. One provider can access them online. So as far as the technology, we have the real-time continuous glucose monitors, which you don't need to scan. They're giving you readings, intermittently scanned, and professional CGM. And real-time CGM, the prototype is Dexcom, which has a sensor and it has a transmitter. And you can have a reader or a phone app. What's replaced this is the new Dexcom G7, which is a very small sensor. It needs less warm-up time. You have a 12-hour grace period. If you forget to take off a sensor or you run out of your next sensor, you have a 12-hour grace period. It's very accurate, and you need to be sure to remove it if you have any advanced imaging studies or diathermy during surgery. These are compatible with certain insulin pumps, which is the next stage for those people who need pumps. Freestyle has now come up with a thinner sensor. Again, it's this last 14 days. Not as accurate, but very, very usable. And I particularly like using it. And the Freestyle 3 does not require a reader, but the person has to be able to use a phone app. So some older people prefer the Freestyle 2 which has a small reader, which shows you the readings, the bar graphs, the time and range, everything on this small visual reader. And I find that that's very important. So I'm going to kind of skip over this information. And just to show you an example of a case, to show glucose profiles over um, a day, and this can be superimposed, over 7 days, 14 days, of a woman who had nighttime hypoglycemia, and the alarm kept going off, and there's alarm fatigue. So people actually tended to turn off their, alarms, which they shouldn't do. So when you looked at the profile, you saw there are lots of excursions. There's a lot above range, especially after meals. You see postprandial hyperglycemia, but you see the hypoglycemia is in the early hours and after midnight. So what can be done for this woman is to reduce her dose of basal insulin, and she was taking rapid-acting insulin at bedtime. So you move the rapid-acting insulin to dinner time to control the postprandial hyperglycemia. So this is a way that you can analyze glucose profiles and improve your decision making, which is much more sophisticated. We have quite a bit of data from small studies that CGM is useful in the post-acute setting. And this 35 patient study, it allowed detection of hypoglycemia, which was not detected by finger sticks. And a larger study of 97 patients in long-term care facilities, again, they divided them into point-of-care testing and decision-making made with point-of-care with a blinded CGM, and decision-making made using the CGM data. And they showed that the CGM detected a greater proportion of patients with hypoglycemia. And that's the important thing, is it detects hypoglycemia when point-of-care testing can miss it. Okay. So I think that's the important thing in the data. And factors affecting use of this technology, it's growing and people are training themselves, and that's really admirable. So it depends on the site of care or what the capability is in that site, staff training, what the facility culture is, and even internet connectivity, very important. Okay, so there are definitely factors, and in terms of also clinical knowledge, supervision of clinicians, and how to actually respond to this data in terms of adjusting treatment. Let's say you're on steroids or somebody needs temporary tube feeding. How do you respond to this data to make rational changes? Okay, and then payment, of course, is an issue, and for skilled nursing facility, it would have to come from the per diem charge. But in group homes and ALFs, CGM is covered as durable medical equipment by Medicare Part D. And it is covered for Medicaid patients for those who are disabled or less than 18 years of age, which may apply to some of our facilities. So I'm going to stop right here. I really thank you for your attention, and I welcome any questions which can be sent to me by the organizers. And thank you so much for inviting me.